So, hello everyone. I guess we can start with the webinar now. Welcome to today's webinar. The topic is diagnosis and management of TSH resistance. My name is Camelia and I'm a project manager for Work Package 6 and I will be your technical host today. First, I want to thank the organ of this webinar. And the questions you can ask to the question box in the upper right corner. All questions will be answered at the end, and you will be able to see a recording of the webinar on our YouTube channel. So without further ado, I will give the word to our chair today and to present all of the speakers.
Thank you very much, Camelia, and very welcome indeed to everyone. It's my great pleasure to introduce you to Professor Luca Persani. Luca made sure there was a very exciting webinar on TSH resistance, and he has invited different people from Milan to all address different aspects on TSH resistance. But first, Luca will start with an introduction to this rare thyroid disorder. So, Luca.
Thank you, Edward. Can you hear me? I guess yes. Yes, welcome to everybody. Today we will discuss diagnosis and management of TSH resistance, and in particular we will focus on the partial TSH resistance. In fact, we have different level of resistance at the thyroid level to TSH stimulation. First, there was a first description by the group of Refetov in 1995 of this family with biallelic mutation in TSH receptor, inactivating mutation of TSH receptor that was associated with mild thyroid hypoplasia and a normal free T4. It was a condition that was autosomal recessive. Soon afterwards, the group in Belgium of Professor Visser described this case of complete resistance in which the affected people had very high TSH levels and profound hypoplasia and severe congenital hypothyroidism. Then we came with the evidence that was also another form, the mild form of resistance that was associated with only one affected allele with a mild elevation of TSH, like the ones that we find in subclinical primary hypothyroidism, and normal free T4 and the normal thyroid gland. And this condition is inherited in a autosomal dominant way. So this was the first family that we had in Milan, and you can see that we observed this because in the family, in this original family, we had a compound heterozygous person with this kind of thyroid function test, and then the other parents and the brother had heterozygous variants with mild TSH elevations and normal free T4 and the normal gland. So we have this kind of situation, and we believe that in this kind, the partial TSH resistance that could be associated either with monoallelic, as in this case, or compound heterozygous that, however, maintain a certain sensitivity to TSH, we have a condition of compensated hypothyroidism, so that the elevation of TSH is able to bypass, to overcome the resistance at the thyroid level. How is frequent this situation? The situation is rather frequent. You can see that this is a node table that we published in 2013 in this review in molecular and cellular endocrinology. There was a paper from Japan that illustrated the results of congenital neonatal thyroid screening or congenital thyroid hypothyroidism. So they evaluated more than 300,000 neonates, and they found that biallelic forms were quite rare, and they calculated the prevalence of monoallelic form on this basis, and they found that 1 out of 200, around 200 babies could have a heterozygous mutation in TSH receptor. And evaluating all the studies on that we performed in Italy on several subjects, with these are all the studies where we calculated this. You can see that we found 1 out of 10 subjects in pediatric young adults that were carrier of TSH variants. Among all the causes were cohorts where we excluded the possible presence of an autoimmune disease. So in non-autoimmune hyperthyrotropinemia, we have 1 variant out of 10 subjects, and we calculated that this might be the second cause of hyperthyrotropinemia, at least in pediatric and young adults. So I leave you with the other presenters. So first we have Elisa that will talk about genetic and molecular studies. You will learn that other variants in other genes may have similar clinical features. Then Simone will illustrate you how we perform the diagnosis of these cases. Then Irene will discuss with you the possibility to treat, yes or no, these kind of patients with partial TSH resistance. And then Alice will present you a survey that we want to circulate among all the Endo-ERN members that will investigate how many cases of this kind we have in Endo-ERN, and what is the management that is currently run in all the centers. Thank you. I leave so with this to the chair the stage.
Thank you very much for the introduction, Luca. Really helpful. So the next speaker indeed is Elisa, and she will talk on the genetic and molecular studies. And Elisa, is it correct that I might hear some background noise? I'm unsure whether I'm the only one.
Do you know? I cannot hear anything here. Do you have some background noise?
Not now anymore. But anyway, maybe I was wrong, but I did hear some noise on the background. But feel free to start up your presentation. Can you share your screen?
Yes. Okay. Is everything fine? Can you see the presentation?
Yes.
Okay, perfect. So, good afternoon, everybody. If we search for the OMIM database for the TSH resistance terminology, we can see that different genes pop up, and the one mostly belonging to the macro area of congenital hypothyroidism are involved. Specifically, the gene most frequently involved in TSH resistance are the TSH receptor, PAX8, alteration in a short tandem repeat on chromosome 15, and the gene coding for the G-alpha subunit. Defects leading to TSH resistance may act in different way. So they may be inactivating mutation in the TSH receptor gene itself, the presence of reduced quantity of TSH receptor secondary to defects in other factors that control TSH receptor expression than the TSH receptor itself, post-receptor defect in signal transduction, like for example in G proteins, and defects in the transcriptional master regulators of thyrocyte proliferation and differentiation. From a general point of view, Mainly, the pathology, it is due to biallelic TSH receptor variants, either in homozygous or compound heterozygous pattern. In rare cases, for example, in the presence of PAX8 variants, the disease is inherited in a dominant, autosomal dominant pattern, while the heterozygosity may lead to partial resistance only in the case of TSH receptor gene. From the interaction between clinical spectrum and the genetics, complete loss of function mutation usually results in congenital hypothyroidism. Partial loss of function mutation may induce subclinical or mild hypothyroidism and sometimes only detected on newborn screening. And the heterozygous carrier may present with isolated hyperthyrotropinemia only. Now let's start with TSH receptor gene. That is the most common genetic alteration found in TSH resistance. As Professor Persani has already told, homozygous or compound heterozygous mutation usually give rise to either complete or moderate resistance, while the presence of only monoallelic mutation give a mild phenotype. I present here 3 different examples of families with TSH resistance. In the first one that you can see in the table, it is a typical pattern of inheritance in which the proband that has altered TSH levels in the presence of normal T3 and T4 hormones has inherited one mutation from each parent, and both the parents are indeed healthy. In the other 2 cases that I show you here on the right, we see 2 different families. One in which compound heterozygosity of 2 different TSH receptor mutation cause a severe TSH resistance with high level of TSH, while in the other family members with only one of the 2 mutations, we can see some mild increase in TSH levels. In the last family, it is a slightly different case in which only one mutation it is inherited in a dominant autosomal dominant pattern. And in this case, we have significantly elevated TSH level because this mutation is known to exert a dominant negative effect, meaning that the altered variant can also affect the expression or the functionality of the wild-type copy of a TSH receptor itself. The alteration of TSH receptor may affect both protein maturation and expression on the plasma membrane, may affect the ligand binding domain, and may finally affect also how the TSH receptor itself couple with G protein and proceed to downstream signaling. Variants that are found in the extracellular domain of the TSH receptor, so the part of the protein that interacts with the TSH itself, usually induce either reduced expression and or alteration of the ligand binding. I report here 3 different examples. The first one, that it is known to have an intracellular entrapment of both the affected mutant TSH receptor and the wild type in a dominant and negative pattern. The second one, that it is known to induce both retention of the TSH receptor itself intracellularly, so no membrane expression, and at the same time, the part of the TSH receptor that can be on the membrane has a reduced binding to the hormone itself. And the last one that has a normal binding ratio to the hormone, but it's not able to transduce signaling. On the other hand, the variants that are present on the transmembrane domain usually induce an altered expression and maturation of the protein itself or defective activation of the G protein coupling. In this case, we might have either an impact on the cyclic AMP signaling alone, on the GQ signaling alone, or both pathways may be affected at the same time. Moving forward, the second most frequent genetic alteration responsible for TSH resistance, although much more rare than those found in TSH receptor, are alteration in PAX8 gene. In this case, we have heterozygous mutation that can cause a resistance that it is clinically and functionally the same as that one caused by TSH receptor mutation. The main difference it is that in this case, we only have an autosomal dominant segregation pattern through the families. But the clinical presentation may be complex or variable anyway, because in the case of PAX8 gene, we may have some different phenomena like incomplete penetrance, the presence of parental mosaicism, and other factors that may affect the thyroid growth postnatally. Here I show two different pedigrees. The first one, it is the classical autosomal dominant pattern of segregation, in which one affected parents pass the pathology and the genetic alteration to the two sons and daughters. In the second case, we have a slightly different presentation because yes?
I don't see the presentation anymore. I'm unsure whether I'm the only one.
I also lost
See
it.
the presentation?
Yeah, we
Can I
do
try
see.
to get out and back again?
I do see.
Can you share your screen again?
Can you share your screen?
Because I'm not, I don't have the ability to share the screen again. I can see. Wait. Okay, now it's coming.
Okay.
Wait. See? Now?
This is the screen. Yes, if you can put it in presentation mode.
It is in presentation mode for me now.
Yeah.
Is it okay for you as well?
Yeah,
Yes.
please continue. Yeah.
So, okay, wait. Let's go back to PAX8. Okay, now you can see everything. Okay, so what I was saying. So I was showing here two different families. The first one in which there is a classical autosomal dominant segregation pattern, in which the mutation segregate with the phenotype from the father to the two sons and daughters. But in the second case, we have a slightly different presentation in which the proband was found to have congenital hypothyroidism at the neonatal screening, although with a decrease of TSH levels later in life. And the same variant has been found in the mother, that it is not affected but by congenital hypothyroidism, but that still present with mild adult onset hypothyroidism. Even for PAX8, the genetic alteration can affect all the domains of the gene and the protein, although most of the variants are found in the paired domain, because disruption of the paired box domain may cause alteration to the capacity of this transcription factor to bind to the target sites, and thus effectively reduce the expression of the target gene. Other variants have been described in the promoter of PAX8, and in this case they act by disrupting the self-promoting regulation of PAX8. And other variants has also been found to impact the synergism with other thyroid transcription factors, such as NKX2.1, or to negatively affect the recruitment of a transcriptional coactivator like P300. Recently, a new light has been brought on the role of short tandem repeats on chromosome 15. The association with TSH resistance was already demonstrated 20 years ago by genetic linkage studies performed on 5 large families. But the newer study also provide the specific mechanism of action by which alteration in these short tandem repeats may act. And there are 2 different proposed mechanisms of action. The first one, it is that indeed alteration in the length of the short tandem repeats change the binding of different transcription factors to their binding element, thus changing the transcriptional dynamic. And the important thing it is that although no specific transcription factor has been physically proved to interact with this area, in silico prediction indicate that one of the fundamental thyroid transcription factor, FOXY1, may be implicated in this mechanism. And the other effect by which alteration in this short tandem repeat may disrupt the downstream TSH signaling is by dysregulation of 2 different miRNAs that in turn affect one of the main signaling pathways that regulate thyrocyte proliferation and activity, that it is the mTOR phosphatidylinositol AKT pathway, thus impacting the effect of TSH downstream of the TSH receptor signaling itself. And it is important to consider this kind of alteration in patients with either TSH resistance or congenital hypothyroidism. We start screening for this variation, and I can show you here that in one of our cohorts in which we evaluate patients by whole exome sequencing, we were able to identify also these short tandem repeats in patients that otherwise did not have any known genetic cause. At last, there are other thyroid-related genes that may give clinical presentation that partially overlap with TSH resistance, that are mostly either thyroid transcription factor like FOXY1, NKX2.1, and NKX2.5, or gene coding from protein affecting the downstream of TSH receptor signaling like gene ACE1. In these 4 genes, we have NKX2.1 and NKX2.5 that are usually different than the classic TSH resistance presentation because they give a much more complex syndromic phenotype, while on the other case, FOXY1 and GNAS give a much more variable clinical presentation. In the case of FOXY1, that may range from Bamford-Lazarus syndrome to a simple predisposition for congenital hypothyroidism or for adult onset hypothyroidism, thus covering more or less all the spectrum that is affected also by TSH receptor alteration. On the other hand, GNAS1 is a little bit more particular because
Elisa,
yes.
Sorry to interfere, but how many slides are left? I'm just looking at it.
It's last one.
Okay, amazing. Thank you.
And in the case of GNAS1, it has a much more variable presentation. And usually it is responsible of pseudo-hypoparathyroidism type 1A, but it has been reported in different families in which the first clinical presentation of the proband was either congenital hypothyroidism or resistance to TSH, and the presence of other syndromic traits were tracked backward in the family. In conclusion, TSH receptor biallelic mutation may induce complete resistance, moderate resistance, and when present only as monoallelic mutation in mild resistance. Other isolated genetic alterations to take into consideration are PAX8 and the chromosome 15 short tandem repeats, while alteration in FOXY1, NTX2.1, NTX2.5, and GNS1 although may give a phenotype that partially overlap with TSH resistance, usually give rise to much more complex syndromic presentation. Thank you. For your attention.
Thank you very much, Elisa, for the clear presentation. Thanks. So let's move forward with the next presentation given by Simone Rodolfi, who will talk about the diagnostic workflow. Please go ahead, Simone. And Elisa, do you mind muting yourself? Thank you.
Yeah.
Yeah, thank you for the introduction. Now let's talk about the diagnostic flowchart of TSH resistance. And as already shown, the true prevalence of TSH resistance is unknown, but up to 10 to 20% of patients with raised TSH, negative thyroid autoantibodies, and normal thyroid US scan can be diagnosed with TSH resistance. So obviously, the diagnosis approach is different between complete and partial form. Complete form are detected by the neonatal screening performed with Hill prick test, while partial form can be identified only in TSH-based neonatal screening and depending of the cutoff of TSH used by each laboratory. In terms of thyroid function tests, complete form are characterized by markedly elevated TSH, while partial form are more heterogeneous, with usually a slightly elevated TSH and normal T4. Both forms are characterized by negative thyroid autoimmunity and with measurable serum thyroglobulin. Thyroid ultrasound in complete form shows an hypoplastic but ectopic gland, while in partial form, thyroid ultrasound thyroid gland is usually normal because the elevated TSH can normally stimulate a normal function and the normal growth of thyroid, bypassing the partial TSH resistance. If we perform a CT scan for differential diagnosis in complete form, it will show paradoxically complete form are similar to thyroidgenesia because sodium iodide symporter is TSH resistance. So in a complete TSH resistance, thyroid is unable to uptake the iodium. Finally, we need to perform a genetic analysis to confirm TSH resistant diagnosis, and it will show autosomic recessive inheritance for complete form and both recessive or dominant autosomic inheritance for partial form. In terms of differential diagnosis, instead, we need to consider other thyroid function patterns similar to partial TSH resistance, so hyperthyrotropinemia. These conditions are usually more common, such as subclinical hypothyroidism or LT4 malabsorption, NTI recovery, or the use of drug as amiodarone or iodinate contrast media, and assessing complete clinical history and a correct anamnesis, we can usually confirm or exclude this condition. Instead, polyethylene glycol precipitation is necessary to exclude or confirm macro TSH as assay interference. Other mild congenital hypothyroidism needs a specific test in order to suspect it. For example, radioiodine uptake that is impaired in sodium iodide symporter defect, or perchlorate test that is positive for DUOX2 defect due to a defect in the organification of iodide. Complete TSH resistance instead needs to be differentiated from other congenital primary hypothyroidism, such as athyrosis or ectopic thyroid tissue, which can be excluded using a ultrasound scan or CT scan. Other causes of thyroid hypoplasia instead need to be suspected considering associated abnormalities. For example, NKX2 defects are associated with neurological or pulmonary defects, while FOXP3 defects are associated with kidney impairment. Now, I briefly report two clinical cases in order to underline some key aspects of the diagnostic workflow of TSH resistance. The first one is a 22-year-old female which performed a reflex TSH for familiarity. Both her mother and her sister, in fact, were diagnosed with Hashimoto thyroiditis. The patient was asymptomatic. Hyperthyroidopenia was confirmed in 3 different blood samples, but hormone thyroid were normal. Thyroid autoantibodies were negative, and also thyroid ultrasound scan was normal. So this is a typical scenario in which we can consider TSH resistance. The patient was asymptomatic. We have hyperthyroidopenia, and thyroid ultrasound scan and autoantibodies were not congruent with TSH. Also, other investigation, peripheral marker of hypothyroidism, such as normal cholesterol, were normal. So we perform a genetical analysis with NGS, which identified a TSHR mutation classified as variant of unknown significance. That's why we assess all her family members with biochemical, ultrasound, and genetic analysis, and we found out that the same mutation was carried by her brother, her sister, and they inherited it from her mother. So the familiar segregation of the variant were autosomic dominant, and in this case, the diagnosis of the mother was the more challenging because she was also correctly diagnosed with Hashimoto thyroiditis. She had positive autoantibodies and ultrasound scan, which shows hypoplastic gland, hypertrophic gland. So important is to underline that in members with the same family carrying the same mutation, TSH can be variable, not only in members of the same family, but also intra-individual in different times. TSHR defects so should be genetically documented in order to avoid an incorrect diagnosis and management. For example, her sister, which was misdiagnosed. The second one instead is a 28-year-old male which performed a reflex TSH for occupational medicine visit. Also, in this case, we have 2 blood samples which shows hyperthyroidopenia, normal thyroid hormone levels, negative autoantibodies, patient was asymptomatic, and his family history was apparently negative. Also, thyroid scan was normal. In this case, as we have seen before, considering the differential diagnosis, the more probably was the macro TSH, so an assay interference. That's why we perform polyethylene glycol precipitation test, but the recovery of TSH post-treatment was about 85%. So macro TSH was excluded. So we perform also in this case a genetic analysis for idiopathic hypothyroidism, and we found out a mutation of TSH receptor already described in literature and described as pathogenetic. So we assess his family member, but biochemical and ultrasound assessment was negative for all his family members. The mutation can be considered a de novo mutation, and we don't need to perform a genetic analysis in his family members because the mutation is pathogenetic. So with normal biochemical and ultrasound assessment, we don't need to proceed with other genetic analysis. That's all, and thank you for your attention.
Thank you very much, Simone. A really clear presentation. Let's move forward to the next presentation by Irene, which will be on the, whether or not to treat TSH resistance. You're still muted.
Okay, sorry. Can you see my presentation?
Yeah, perfect in
Okay.
presentation mode. Thanks.
So let's move to the treatment, if to treat or not patient with TSH resistance. As we heard before, this condition can be heterogeneous from the genetic point of view, with mutation in the TSH receptor or other genes. And the phenotype can be variable, and the compensation of this patient depend on an adjusted set point that is able to overcome the receptor function. So we have features of partially or fully compensated patient, and we talk about this as the treatment in case of severe form that are congenital hypothyroid patient is clear and need to be started promptly after diagnosis. However, the management of isolated hypertrophinemia remain controversial, and in this case, this is not only in the case of TSH receptor mutation, but in general, we need to decide to treat or not based on the risk of progression over time that can be different in case of associated thyroid autoimmunity, as shown before by Simone, or in case of specific mutation. Then we have to consider the thyroid of our patient, and of course the symptoms and the signs of hypothyroidism that can be different in children, the pediatric age, or in an adult patient, as well as the comorbidity of the patient. This is well exemplified in this review from Professor Salerno, and here is clear we are moving in the non-autoimmune subclinical hypothyroidism, and clearly we have to consider the genetic background of this patient, if is an idiopathic subclinical hypothyroidism, or in case, and we need to consider the thyroid as well as the progression over time to consider if treat or not with LT4. In case of the TSH receptor mutation, we know that, for example, a patient carrier of biallelic mutation, either homozygous or composite heterozygous, has an higher risk of progression. This is well exemplified in this study, where people carrier of two mutations, biallelic mutation, have an increase of TSH over the time, as well as a significant decrease of LT4 over time. So in case these patients are not treated, we need to follow up their thyroid function very closely, while heterozygous patients tend to have a stable TSH as well as stable FT4 levels. However, this patient needs a lifelong surveillance, and the management should be individualized. Here I've put together data from different publications, and you can see that biallelic mutation have an increase of TSH over time and a decrease of T4 over time, but we have also some exceptions. So, for instance, these two homozygous patients have an improvement of their thyroid function over time, while this heterozygous carrier had a overt hypothyroidism, and over time he need to start levothyroxine. And indeed, if we found an heterozygous mutation in some special category, not only children, but in case of children, we know baby or small for gestational age, or those born after assisted reproduction technique may be more at risk of hypothyroidism. And of course, in adult, we need to check the personal and the family history of autoimmunity. And also the genetic background is important, as shown before by Elisa. PAX8 heterozygous mutation are associated with a non-congenital early onset hypothyroidism, and we need to check in this case over time their thyroid function, because there is a sort of progression of the thyroid damage. And you can see here in this figure that we have a normal thyroid at birth, and then over time, this is a patient at the age of 15 years, he had a certain involution, and here you can see that this thyroid gland is atrophic and clearly hypoechoic. And in order to have data regarding the progression of this hyperthyroidopenia, we can also consider some study regarding the natural history of mild non-autoimmune subclinical hypothyroidism. Indeed, as shown before by Professor Persani, there are a large number of patients with TSH receptor mutation in this category. Of course, the prevalence is variable depending on the kind of population that we study, for instance, adult or pediatric patient. And here I've put together data from different studies. In most of these studies, there's no genetic assessment, so we can think that a certain number of patients with TSH resistance are comprised in these cases. And also these data are reassuring, because we can see that non-autoimmune subclinical hypothyroidism has a low risk of worsening in different from what we observe, for instance, in Hashimoto thyroiditis, in which the stabilization or the worsening of thyroid function is clearly more frequent. And as shown before by Simone, also in patients with TSH resistance, we have to consider the presence of thyroid antibody and, for instance, associated chromosomal disorder, or also other autoimmune conditions, such as patients with an associated celiac disease. Then we can ask if these patients that are well compensated, if are left untreated, if there is some risk. And this is a study on pediatric patients. They were studied patients left without therapy because they had a stable TSH and normal FT4 and FT3, and other they were treated and for long term. By comparing this patient left untreated since birth, you can see that there are no significant difference as far as the auxological parameters, so the height, the BMI, but also some biochemical parameters of hypothyroidism, such as total cholesterol or creatine phosphokinase are normal. The bone age and the bone mass are comparable and normal, and also the intellectual outcome outcome are comparable. So it seems that this patient, if left untreated, develop like the patient treated with levothyroxine since birth. In addition, also in this study, there were several adult carriers that were identified for after family screening, and they had no evidence of over disease. Most of them has borderline high TSH level, and some other were at a normal TSH. The thyroid gland were normal. They had a normal metabolic profile, a normal reproductive health, and normal cognitive outcomes. And in particular, even if they had high TSH since birth, they had no pituitary enlargement. So this suggests that there is also a long-term benign outcome. However, in some of these patients, the disadjusted pituitary set points stay on a balance, on a fragile balance, and indeed, as we can see, as shown before, the appearance of an acquired thyroid disease, in this case Hashimoto thyroiditis. This is a case published by Professor Tonacker, and you can see that this patient was well controlled without treatment before the appearance of thyroiditis, and then later the TSH goes up and the patient require levothyroxine, and also the echographic pattern change over time consistently with the presence of autoimmunity. Here I show another case. This is from our court. It's an heterozygous patient with this mutation that is already in heterozygous state, already described in the past, and you can see that the thyroid function of our patient are more or less similar to this heterozygous patient previously reported. After an infection of COVID, is developed a subacute thyroiditis, and you can see that after this thyroiditis, he had a overt hypothyroidism, and he need to start levothyroxine. So what we can find from clinical study? So we know that the risk of progression to overt hypothyroidism, either in idiopathic hyperthyroidopenia and in patient with compensated TSH resistance, is low, but we need a careful follow-up, because especially homozygous carrier and patient with PAX8 mutation can develop a overt hypothyroidism over time. So we need to follow up them if they are live untreated. And there's no significant difference in the outcome, especially neurocognitive development, growth, bone density, and metabolic profile between treated and untreated patient with a compensate TSH resistance. So we don't need to treat any patient. However, we need also in the adult age to consider that acquired thyroid disorder may destabilize a compensated TSH resistance. There are still some open questions, so we have not specific guidelines for specific categories. So oligogenic patients, so patient carrier of different variant in different genes, as well as for syndromic form, such as mutation in the GNAS locus. This patient, for instance, has obesity, so we don't know if they may benefit from LT4 treatment. Again, it's not clear if the recently identified patient with Jones tandem repeats mutation on chromosome 15 need the treatment, as some patients develop goiter, and we don't know if this goiter is TSH dependent or not. So we don't know really if we need to treat them. And again, although the data in untreated adult are reassuring because they have no long-term problems, but this category is not been assessed for other outcome, for instance, the long-term cardiovascular risk, the fertility, or pregnancy management, for instance, in case of medical assisted reproduction. And this was my last slide, and then thank you for your attention.
Thank you very much, Irene. Very helpful and insightful what you shared. And then the final presentation will be given by Elisa on a survey that will be sent out. So please go ahead. At the moment of presentation, you seem
Do you
frozen.
see my screen and do you hear me?
We hear you and we do
What?
see your screen. Almost, I think. Yeah. We see it in full presentation. Go ahead.
Okay. Thank you and good afternoon, everybody. I will now present the survey that we made in order to better understand your clinical approach to TSH resistance. There are 21 questions, but some are very quickly to answer, so I think it will take you only 10 minutes to complete it. So let's begin from question number 1, that is about the definition of partial TSH resistance, and if you agree that it is defined by persistently elevated TSH levels since birth, with normal free T4 and free T3, absence of hypothyroid symptoms, normal thyroid morphology, and no evidence of autoimmune thyroid disease. And in the context of partial TSH resistance, what are the criteria that you consider essential for the diagnosis? And you can choose more than one. So, for example, persistent and stable TSH elevated levels, normal free T4 and free T3, absence of clinical signs or symptoms, normal thyroid morphology on ultrasound, absence of autoimmunity, some germline mutation like TSH receptor gene, genus gene, or short tandem repeat on chromosome 15. And another question about the definition, this time of complete TSH resistance. And if you agree that it is defined as congenital primary hypothyroidism characterized by a very high TSH, low circulating thyroid hormones levels, and hypoplastic orthotopic thyroid gland, low or even absent thyroidal radioactive iodine uptake. And in the context of complete TSH resistance, which criteria do you consider essential for diagnosis? Like severe congenital primary hypothyroidism, a normal or hypoplastic thyroid gland in normal anatomical position, low or absent thyroidal RAI uptake, a normal TSH bioactivity in vitro or but impaired in vivo response, low free T4 and free T3, absence of autoimmunity, autosomal recessive inheritance, and the allelic mutation in TSH receptor gene. We are interested in knowing how many patients with complete and partial TSH resistance are currently under your care. And in your clinical practice, if you need to make a genetic diagnosis of a suspected TSH resistance, if you can request the genetic analysis directly, or if you must refer the patient to a clinical geneticist. And when you decide to perform the genetic test in a partial resistance, what are the clinical or biochemical features that suggest you to perform the genetic test, like family history of hypothyroidism, clear autosomal dominant inheritance, or you do it systematically in all patients with elevated TSH levels and normal thyroid gland, or when clinical or biochemical findings are atypical or inconclusive, to confirm a PHP diagnosis, or to guide the levothyroxine treatment, or to provide the familial genetic counseling, or only for research purpose. When you do a genetic test, which kind of testing methodologies do you use? So direct sequencing, NGS, exome or genome sequencing, or true analysis? And when you find a mutation, which of the following mutation do you consider supporting the diagnosis of TSH resistance? So TSH receptor, GNAS gene, short tandem repeat on chromosome 15, PAX8, FOXY1, or also genes associated with dysharmonogenesis like DUOX2 or SLC26A4. We are interested in knowing if you believe that a short tandem repeat mutation on chromosome 15 cause TSH resistance, or if you need more data or clinical and treatment indication for this in this case. And when you found a VUS, so a variant of uncertain significance, how do you assess the clinical significance of this mutation in a patient with suspected TSH resistance, with in-house in vitro or in vitro functional studies, with functional studies through collaborative research, ACMG variant classification criteria, in silico analysis to predict variant pathogenicity, or familial segregation analysis. And once you have diagnosed a patient with partial TSH resistance, do you provide levothyroxine treatment? This question is about a clinical case of a 32-year-old asymptomatic woman, which was found with TSH 9.6, normal free T4 and free T3, negative anti-thyroid autoantibodies, normal thyroid ultrasound, and negative family history for thyroid disease. At genetic testing, she was found with an heterozygous TSH receptor variant previously associated with congenital hypothyroidism in homozygous state. And her thyroid function 6 months earlier was found with the TSH 8.3. In this context, would you start levothyroxine treatment or not? And if the same patient had a DUOX2 mutation, would you treat her? And if she had the maternally inherited GNAS mutation in a syndromic form of PHP1A, would you treat her? And if the same patient had a PAX8 mutation, if she had a short tandem repeat mutation on chromosome 15, this question is about the in case of untreated partial TSH resistance, which evaluation would you routinely perform during follow-up in this context in pediatric patient? So, for example, a periodic measurement of thyroid function, thyroid ultrasound, thyroid autoantibodies, physical examination and oxological assessment, general blood test, and reported symptoms from parent or teacher, and the periodic neuropsychological testing. And the same question, but in adults. So even in this case, biochemical thyroid function, thyroid ultrasound, thyroid autoantibodies, physical examination, cardiovascular risk assessment, symptoms and standardized quality of life or symptom questionnaires. And if you answered yes to question 14, that was the question about the clinical case with the girl that was found with the heterozygous mutation of TSH receptor, and if you decided to treat her, which criteria do you consider when deciding to prescribe levothyroxine treatment in this patient with partial TSH resistance? In pediatric patients, so if you treat all pediatric patients with partial TSH resistance, or if you yes.
Sorry to interrupt you. We are already at the hour of the webinar. So how many questions are left?
Only one left.
Okay, very good. Yeah.
Okay. So this is for the characteristic for pediatric patients, and then the same question for adult patient. And last question, if in familial cases when a relative with hypothyroidism of newly diagnosed patient with partial TSH resistance is found to carry the same variant, do you consider withdrawing levothyroxine treatment that was initiated before the genetic diagnosis or not? Thank you for your attention and for your future answers.
Thank you very much, Elisa. Thanks very much to everyone, to all presenters. Really nice. Actually, I also like the format with different people all having a small presentation. So thanks to Luca for proposing this. Although I acknowledge we are already a bit over time, I suggest that we can use the next 5 minutes or so to address questions. I don't see questions immediately in the chat, so I was curious if I could ask a question. So what happens with TSH resistance if a woman gets pregnant? What do you have experience there? What do you expect biochemically to happen? Yeah, I don't know. Maybe I don't.
Irene can respond.
Might have a response to it.
So I think we need to check if this TSH remains stable or not, but we have also to keep in mind that in some cases, for instance, medical assisted reproduction, the thyroid function can change considerable during this technique, and maybe we can give levothyroxine just to support this patient. We have a recent case, for instance, because we are evaluating children at birth, and we have found a child with TSH resistance, and the mother had 3 different assisted medication cycle. She became pregnant at the last cycle when she was treated by the gynecologist with levothyroxine. And in this case, that lady, we had diagnosed the TSH resistance too. So she had an hypoplastic thyroid gland. So in some case, I think that since in pregnancies there is a sort of overwork for the thyroid, in some cases we can have a decompensation. I think that we have also to check 3T4 because in some case during pregnancy, especially for the fetus side, maybe the levothyroxine is not enough. So I think we have to check each patient case by case because we have no data. But from the literature, we know that also patients with high TSH, and in most cases we have not the data from the echography, but I think it's similar to what is reported for non-autoimmune idiopathic hyperthyroidopenia. We know, for instance, that high TSH can be an adverse the outcome of pregnancy. So I think that we need to decide patient by patient until we have no specific data. For instance, it could be useful, in my opinion, to check clearly in a clinical study, because we can't do the genetic whole patient in some selected cases, and to see, treat a sort of randomized trial to see if we have some difference. Yeah. Or maybe also in patients diagnosed when they were children, now they are in their 30s. So maybe they are searching a pregnancy.
Fair enough. Thanks. Thank you very much. I don't think there were other questions in the chat. So I don't know the question to, I don't know, Elisa or Simone. So if you do see a new, well, actually a couple of questions. How often do you see novel variants, or are the majority already identified? And if a variant is new, would you advise to proceed with functional testing, or is that not relevant?
In our cohort, we mostly see known variants, or on a known residue, but with a different amino acidic change. From our experience, I can say that when we have a variant of unknown significance, so not previously reported and classified according to the HCMG criteria, like of unknown significance, so not benign and not clearly pathogenic, it might be useful to perform an in vitro study, at least to check if the variants affect the expression and the functionality of the TSH receptor. In the case of the TSH receptor, that it is the most easily studied, because the prediction tools, in silico prediction or artificial intelligence-based tools, although more reliable than in the past, are still not on point in predicting the protein functionality. So if we want to see a clear genotype, phenotype, and protein action correlation, we should definitely go for in vitro studies.
Thanks, I see. Yeah.
I would certainly sponsor also the segregation study if you have available relatives, obviously, and check thyroid function test and the genetic, and then the TSH variant, segregation of the TSH variant, because this would be also informative.
Yeah, I understand. Fair enough. And maybe, if I may, one final question from my side to Elisa. So I was curious what specific question you had, something like, do you believe this short tandem repeat on chromosome 15, is it TSH resistance or not? Can you explain a little bit? Are there people doubting this? These two big papers. What is your? Can you briefly comment on this?
I think that it's a new variant that has been described from the last papers, and so there's not much evidence on it about clinical patients that have this type of variants and how they and how it affects the the thyroid function and in the years. So I think that it's interesting to monitor how it will to evaluate how it will the evidence that will come in the next years about this short tandem repeat on chromosome 15.
Yes,
Thanks,
I agree. Can I say something? Yeah, because we have so far, indeed, the families where these variations, genetic variations were found, were selected on the basis of biochemical phenotype. And the biochemical phenotype was clearly overlapping with the one of TSH resistance. But then observing the adults at variance with those affected with the partial TSH resistance, these some at least of these adults developed goiter. I think that we should see if iodide supply or other things can in some way contribute to this goiter formation. It was found, I must say, also in the families that were studied in Japan, because there was a back-to-back publication from USA and Japan, and the goiter was found in Japan. I don't know if there was some problems in the studies of this family, but iodide should be sufficient in the Japanese. So I don't know. I don't know if there are other supplemental effects of this short tandem repeat that would favor the goiter formation. So I think we need more data.
Thanks. Yeah, I think if I could add, it would be helpful if you sent out this question to put a little bit more explanation, like you did or like Luca did, for people to understand, and also perhaps for the authors of the manuscript, yeah, to understand what the background of the question is. I think so that would be helpful for the people. So
I think we can circulate this among us, this survey, and yes, we can complete, correct some more focus some question, but yeah, I think it would be useful to understand what is the level of knowledge and what is the level of management of this kind of situation.
yeah, I think I applaud this really useful exercise to have this survey and see what the yeah, current practice is and the understanding in the field. I think we are coming to an end of this webinar. So everyone who has stayed until the very end, thank you very much for listening and watching. Thanks again to Luca and Elisa and Simone and Irene and Alicia for the really wonderful presentations. For Camelia for hosting this all, and I wish you a very pleasant evening. Thank you very much.
Thank you.